Washington, D.C. for you folks to get to know. And let me just bring this up. Great. So this particular session, we're going to do this live stream for those patients who could not be here to join us today. It's called Under the Dome, Issues Impacting Your Healthcare. And again, my name is Paul Conway. I serve as the president of AAKP. This particular session, we're recording it, and it will be available at our website, aakp.org, and also it's available on our annual meeting site, which is aakpannualmeeting.org. Public policy is an integral part of the work that we do at AAKP as a patient advocacy organization. And for those of us alive today, we can credit our lives and futures with the public policy decisions that were made years ago by members of the U.S. Congress and former presidents. As we have said before, many do not know this, AAKP was directly involved in the formation of the end-stage renal disease program, the only disease-specific entitlement program in the United States. In fact, it was an AAKP patient that was wheeled onto the floor of the U.S. Congress, dialyzed, and that in part resulted in the vote in favor of the program, legislation that was passed in 1972 and signed by Richard Nixon in 1973. This one particular example from our history at AAKP is an important reminder, I think, to every single patient to understand that the decisions that are made in Washington, D.C. and state capitals impact your health care and your futures. And it's particularly fundamental for you to understand that for organizations like ours that serve a role in the policy process, we cannot be successful on your behalf if we don't work closely with allied organizations who really understand where patients are coming from, what patient needs are, and the intricacies of the public policy process in Washington, D.C., how a law gets passed, how a regulation gets made. And I've put some images up here for you of our work with two organizations, the American Society of Nephrology and the Renal Physicians Association. And I'm very pleased that two of the most influential players in public policy on behalf of kidney patients are here today to share their thoughts on the priority issues in public policy, how they operate, and I want to mention again that we have had the distinct honor of working with them on Capitol Hill. You saw the images up there of different visits that we've made on the Hill with them. And I want you to understand as an organization how we choose the organizations that we work with in Washington. And we ask the questions that are up here on this screen. We want to know that people are trusted, that they're credible, that they're long-term players, and most of all, in the operations of these national organizations, that they keep the patient voice and the patient good at the center of what they do. And I can honestly tell you, having worked under 4 presidents and 3 governors and in a lot of public policy battles, the American Society of Nephrology and the Renal Physicians Association and Todd Ibrahim and Dale Singer, you will hear here in a few minutes, are 2 of the most honorable and respected people and knowledgeable. They understand where we all came from on public policy, where policy is going. And if a congressman or a staff person needs to have an answer that's credible and that they can actually represent as factual, they'll call the 2 of them. So it's a great honor for us to have them here. And I'd like to go ahead and invite up first Todd Ibrahim. He's the executive director of the American Society of Nephrology. And ASN has more than 15,000 members, and it leads the fight against kidney disease by educating health professionals, sharing new knowledge, and advancing research, and advocating for the highest quality of care for patients. Todd's a professional. His skills and knowledge of how Washington works are highly regarded by both congressional staff and elected representatives. And I'm also going to ask at the same time for Dale Singer to come up because we'll do a panel discussion after this. Dale's the executive director of the Renal Physicians Association. RPA is the leading advocacy organization for the nephrology community and includes more than 3,500 members. RPA works to influence and, where appropriate, change laws, regulations, and public programs to accomplish its mission, which is to ensure that nephrologists have the ability to provide the best medical services to kidney patients. Please welcome Dale Singer, Todd Ibrahim. Todd Ibrahim will be our first speaker. Thank you.
Good morning. Thank you, Paul, for that very generous introduction. What I'd like to do is start with a story, and I'll apologize to Dr. Hakim because he's heard this before, but as I think about it, this story probably, hang on, we're just having trouble finding it. I think it's on the desktop. Let's see if this is the right one. It'll be another view of the Capitol. Yes. This very quick story will give you a sense of sort of how Washington works, and it's a very simple anecdote, which was when Bill Bradley, Senator Bradley, came to Washington in 1977, is the junior senator from New Jersey. His good friend, Senator Al Gore from Tennessee, threw a dinner in his honor. And the dinner was at one of those really swanky restaurants where you have one waiter come around with rolls, and then a second one comes around with pats of butter. So it's like roll, pat, roll, pat, roll, pat. And when the waiter with the butter got to Senator Bradley, the senator asked for 2 pats of butter. And the waiter said, "I'm sorry, 1 pat per person." And Bradley kind of looked at him and said, "I'm sorry, you must have misunderstood me. May I have 2 pats of butter?" And the waiter said, I heard you. 1 pat per person. And Bradley, who's known for having a bit of a temper, said, "Do you know who I am? I'm Senator Bill Bradley. I'm a Rhodes Scholar. I led Princeton to the Final Four. I was a professional basketball player. I was a champion with the New York Knicks. I'm now the junior senator from New Jersey. My good friend Al Gore is throwing this dinner in my honor, and I'm a big man. I want 2 pats of butter." And the waiter said, "Well, do you know who I am?" And Bradley said, "No, I don't know who you are." And the waiter said, "I'm the man who controls the butter." 1 pat per person. So whatever Dale and I say today, I think this is the first time we've actually ever been invited to speak together, so this is a historical event. So thank you, and hysterical. So thank you to Paul for inviting us. Just remember that ultimately everything comes down to who controls the butter. The next point I'd like to make is this is my favorite image of the sort of current environment in Washington, D.C. I have been giving Paul a hard time that I can see in his future that he will be Donald Trump's health advisor. So you should start lobbying him now. Paul asked me to answer basically 3 questions. What are ways that ASN supports patients but also collaborates with AAKP? So I'll go through those pretty quickly. The second piece are some current policy and legislative issues that are hot topics in the community. I've tried to focus them really in sort of the research arena. And the third is why should you care and how can you make sure that your voices are heard? And really at the end, I think that's the most important part of this presentation. Everything else is transitional, but I think if we can focus in at the end on this last sort of dual question, I think it'll be a successful presentation. So as Paul said, ASN is a membership organization that consists of health professionals, MDs, PhDs, pharmacists, PharmDs, nurses, everyone who's involved in the care of patients is the membership. And it's a global organization with members in 114 countries. So to go through the top 10 list, the first example of sort of a patient-centric activity is a few years ago, we partnered with a foundation and with Consumer Reports to do a project where we looked at unnecessary therapies and activities and treatments. We came up with a list of 5 sort of things that we thought didn't need to take place in the care of people with kidney disease. And I think what's important, it's less important that list and more important that Consumer Reports has such a broad reach. We're in the process of negotiating with them to do a second round of publicizing these 5 points. But it started to raise awareness about kidney disease in a forum that was less common to most people. And so it was common to very many people, but was unique for our space. The second is earlier this year, we had a meeting with a group of nephrologists, other care professionals, and a few patients to really focus on what's a reasonable patient care advocacy strategy. And philosophically, the thought was that the first principle needs to be what's best for the patient. I think Dr. Johnson did as perfect a job of describing a patient-centric vision and care for the patient. I think using that model or that philosophy and then thinking about the relationship between the patient and the care professional and how sacred that is, and making sure that no policies violate that sacred trust. So what's best for the patient, and then what's best for the relationship between the patient and his or her health care professional. And what we came up with were sort of 4 priorities, and I think these fit well with Dr. Johnson's presentation. Access to transplantation, which I'll come back to in a moment, expanded telehealth and home health care, reducing health disparities, and then really looking at the nephrology care team's role in delivering high-quality care to patients, the highest quality care possible. The next initiative, which Paul mentioned in the beginning, was working together to go up to Capitol Hill. And I hope we'll have a chance to discuss this a little bit after the formal presentations. But the most effective visits on Capitol Hill or in a congressional district office are where there's a health professional and a patient together, and there's a presentation where they can tell sort of both sides of the same story. And whenever there's an opportunity to do that, that is a very effective meeting, and that tends to lead to policy-related changes. So earlier this year, we had the opportunity to work together in the spring and do a series of Hill visits. Then in the fall, a couple of weeks ago, there was a larger effort of 16 organizations representing the kidney community, so broader organizations like AAKP, and then smaller organizations like the PKD Foundation or the Alport Syndrome Foundation. And together we had 16 groups, 100 advocates. We visited more than 120 congressional offices, again, pairing health professionals and patients, family members, other loved ones together on the Hill, and we were able to hit 31 states, which I think was a really nice sort of coverage of the community. In a couple of months, in November, we will have an opportunity to recognize the Medal of Excellence award recipients, Dr. Hull and Dr. Moss, at Kidney Week. And we have an opportunity for them to interact with a number of medical students, residents, fellows, and other trainees over a lunch. And this is the first time we've done this. So I took a photo from last year's, which was a breakfast. So it'll be a lunch this year. Well, there'll be some interaction both with AAKP leaders and ASN leaders, all of these future nephrologists, hopefully, if we can recruit them, and really to have the excitement of both the perspective from the patients, but also the excitement of what's happening in nephrology at this moment in time. So along the theme of workforce, one of the big responsibilities or one of the big activities for ASN, and I think it ultimately becomes a very patient-centered activity, is funding both the workforce, so having on an annual basis putting $3.5 million back into the community in a number of training programs and other activities, but also research grants and funding nephrology fellows and early career nephrologists and scientists to really focus on finding cures for kidney disease. And I think I would argue that while transplantation may be the best therapy or the best outcome would be curing kidney disease. And I think that's what our foundation is really targeting, what we're trying to do from a research perspective. So just to turn to the foundation as one of the final activities, since 1996, we've funded almost 140 researchers. They've published more than 1,600 manuscripts. They've gotten additional funding, so they've leveraged the funding from ASN, and they've been promoted within academic institutions. So really funding the next generation, helping the best and the brightest try to look for cures for kidney disease is the focus of the foundation, which is a separate organization from ASN. As part of the research activities, one of the things that happened last year was there was a request, Representative Marino, the co-chair of the Kidney Caucus, put forward a request to the Government Accountability Office for a report. And the report really is going to do 2 things. First, it's going to look at the federal investment in kidney research. And I'll come to some of the numbers in a moment, but to really look at that as it compares to other diseases. And then to take a step back and say, given the size of the ESRD program and its effect within the Medicare program, is that investment on the research side appropriate, or should there be an additional investment in research for kidney research, both compared to other diseases, but also in terms of what's happening with the ESRD program? Sam Peterson, your past president, has been very involved in helping us launch what's called the Kidney Health Initiative. The Kidney Health Initiative is a partnership between ASN and the Food and Drug Administration, and it really has two goals. One goal is to improve the pathway for discovery and for products to come to market, drugs, devices, biologics, and food safety related issues in the kidney space, but also to look at the patient safety aspects and the efficacy of drugs that may be outside the kidney space, but there's not enough consideration of the effect that those drugs and devices and biologics have on the kidney. It's a partnership, as I said, between ASN and the FDA, and it has more than 70 members, mostly organizational members. And really, we get together with FDA, we identify opportunities. We're currently working on 13 projects that are at various stages of completion, and it's opened up some opportunities. And my sense is, in the next few years, there may be more interest in terms of the venture capital community, investing in kidney discovery, looking at innovation in the kidney space. So something we're really excited about, and on Monday I'm flying to Los Angeles, is we've been in negotiations with the XPrize Foundation to look at what I would describe as a moonshot, to mix metaphors, of is it possible to find someone who's interested in kidney disease, interested in discovery, that would be willing to invest in the space and have a challenge competition, have a prize competition. I will say right now that the XPrize Foundation has 4 prizes in development. One of them is a happiness prize. I'm not even sure I know what that means. I will say that if you look at the scores, which are hard to read here, we're at 72 votes for the kidney disease prize, and happiness has gotten 320. So if you could do one thing for me, please go to the XPrize Foundation's website, go to the prizes in development page, and just start voting for the kidney disease prize, so that when we go on Monday, they'll say, wow, there's been a lot of interest in the kidney disease prize. But this is the group that has privatized space travel. And my sense is if you can privatize space travel and help put people into space, you can help us improve care for patients with kidney disease. And so this is something we're just starting to explore, but I think it's really exciting. So to shift gears in terms of legislative and policy issues, there's 3 that I'd like to address. One is just the annual appropriations process. That's the funding process for kidney disease research. The second is the 21st Century Cures Act, that's what it's called in the House of Representatives. It has a different name in the Senate, but we'll just call it the 21st Century Cures because I think that's the better name of the two. And then the Living Donor Protection Act, which is about to be introduced in Congress. So, as I'd mentioned before, if you think of the research portfolio that the federal government has for kidney disease and you compare it to what it spends on the ESRD program, there's a lot of investment that the federal government makes through the Medicare program for care for patients with kidney disease. There's much less of an investment in kidney research, and it seems that needs to be discussed, and there may be opportunities to invest more on the research side to ultimately find a cure. And when we compare kidney disease to other diseases, our sense is that the numbers are not as aligned as they could be. So if you look at this slide, the federal government, if you just divide the number of people with the disease versus what the federal investment is on an annual basis, you get to spending per patient. And you can see for AIDS, it's almost $3,000 per patient. For cancer, it's nearly $600 per patient. Heart disease, it's a little over $60 per patient. And for kidney disease, it's less than $30 per patient. So this sort of analysis alone has gotten a lot of traction with members of Congress where they're realizing there's a disparity here and we need to do a better job of funding kidney disease research. And I'll come back to this at the end in terms of the role that you can play, because in the current environment where the budget is so tight, there's starting to be a lot more competition between and among diseases. The second piece of legislation is the 21st Century Cures. I think what's important about it is it's both chambers, both the House and the Senate. It's bipartisan, which is rare in the current environment. And it's really trying to focus on discovery, on development and delivery, and trying to be patient-centric. And I won't go through this, but really what it's likely to do is put an influx of funding, and it is an opportunity perhaps to address this discrepancy. And each of the little dates is just all the interventions that organizations like ASN and RPA and AAKP have to comment to make sure that something keeps moving through. The legislative process is a lot of steps, and I think organizations like ours are constantly trying to make sure that we're there representing the community, representing those of you with kidney disease, and making sure that that doesn't get lost in the discussion of the legislation. The final piece is the Living Donor Act of 2015. It will be introduced in the next couple of weeks. It will be introduced in both chambers, the House and the Senate, both by Democrats and Republicans, the same piece of legislation in both chambers, which is nice because that should help in terms of passing it. And so we've started to do the data analysis about the statistics around transplantation and some of the challenges. And Dr. Johnson did a nice job of outlining the opportunity with Living Donor. Specifically, what the legislation would do would be to protect living donors by prohibiting insurance companies from discriminating against them. So that's the first piece. The second piece is it would clarify a living donor's job status. So currently, if you're a living donor, you're not covered under the Family and Medical Leave Act. However, you're a loved one of the kidney recipient would be. So trying to open that up so that if I'm a living donor, I'm covered under family and medical leave is the second part of the bill. And the third is just to provide education. I think ultimately, as I started with the Consumer Reports effort, anything we can do to increase awareness about kidney disease, I think is important. And this legislation includes clauses to do that, which I think will be terrific. So what can you do? Why should you care, and how can you get your voices heard? So just a couple of comments. If you haven't read the book, The Emperor of All Maladies, I highly recommend it. It's described as a biography of cancer, but it talks about how the individuals with cancer and the patient community stepped forward and advocated and raised awareness and got the federal government interested in caring more for people with cancer. And there's a quote, I mean, this is a long quote, I know it's hard to read, but just to highlight the last sentence, because I think it's really important, and it's sort of the thesis, at least, of my comments. If the history of medicine is told through the stories of doctors, it is because their contributions stand in place of the more substantive heroism of their patients. And I think somehow we need to get the patient voice up to Capitol Hill, out into the world, and do a much better job of amplifying your voice, which then gets to the next point, which is an easy way now to amplify your voice is to participate in as many coalitions as possible. So we listed these are the 20 or so coalitions ASN participates in. There are others that may be more appropriate for AAKP, but the point is you have to be involved in all these different efforts, and every time there's an opportunity, say, what about kidney disease? What about kidney disease? What about kidney disease? And if you can do that, and do that enough, you'll start being included. You'll be included in legislative efforts. You'll be included in other activities, and there'll start to be a little bit of momentum. And the next point, and which is my second to last point, is that ultimately it comes back to who controls the butter and who has the most butter. And so there's 2 points made on this slide. And the first is that there was an analysis of NIH funding by diseases, and it was proven that the more advocacy money that was put into a certain disease, AIDS, cancer, cardiovascular disease, diabetes, there was a greater funding, there was more of an appropriations. So that comes from the policy literature, and that's the lower point. The more interesting point, perhaps, and hopefully I can use this, is if you look at this, so this is 2010 expenditures by gun issue nonprofits. So this is the NRA and its affiliated organizations. So think of these as like the state chapters of the NRA. This is the NRA national, and the top here is $300 million. So this is 1 year. They spent between them, let's call it $500 million. This is a national sporting group, which is also with the NRA, which is another $100 million. So let's call this total here $600 million. These groups are all the organizations that were sort of against the gun lobby. So I'm not making a political statement here. I'm just saying that in Washington, the reality is it's not so much the story you tell, which is really important, but you also have to have the resources behind you to help amplify your voice. And in this example, these 2 examples sort of prove that point. And to close, I'd mentioned earlier that there's starting to be a little bit more tension. It used to be that all the different diseases tried to work together, but in the current environment, it's becoming a little more isolated in the sense that it's a little bit of us against them. And one of my favorite quotes is from Gore Vidal, and I apologize for ending on a negative note, but I do think it's important to make this point. And he said, "It is not enough to succeed, others must fail." And I make that point, and I want to make it carefully. All I'm saying is, it's time for us to be a little angrier and to say, wait a second, why are you funding disproportionately other diseases? Why don't you care about us? And that's the point that I think needs to be part of our message. It's an angrier message, but it's one we've been uncomfortable with in the past. And I think we're at a point now where if we are not doing that, others will be. And it won't be just even in the healthcare arena. It's going to be other activities. We need to look out for ourselves, and we need to protect each other, because ultimately we want to cure kidney disease. So I'll stop there. Thank you.
So good morning to all of you. Welcome to beautiful Nashville. I thank you very much for the invitation to speak today. I thank Paul and the staff of AAKP. By being here, you've made a commitment to learning, to becoming engaged, and that's the first step. I think that, as Todd mentioned, it's so important that our leaders in our country hear from the people affected by the disease, family members, and also the people who care for you. But we all are in this together, and not to be cliche about it, but it's a team. And so we need you, your perspective, your experience, and we will all benefit in the end. The pie is getting smaller, the slices are getting smaller, and we need to make sure that kidney disease's slice is a significant part of the pie. So who is RPA? We just celebrated 40 years as the advocate for nephrology practitioners. We were started back in 1974 when right after the Medicare entitlement for paying for end-stage renal disease went into effect, and some of the issues that Doug Johnson mentioned in terms of doctors not getting paid to take care of patients with kidney disease was a huge problem. And so a bunch of physicians got together and said, we need to figure this out, and there was born RPA. And so our three strategic priorities remain true to our core when we were created. It's a three-legged stool: advocacy, professional and business success, and high-quality patient care. And our core competencies are in the realms of advocacy, and we believe we are the credible go-to source for quality and reimbursement issues, and that's what I'll be focusing on in terms of legislative and regulatory issues and how you all have had an impact and can continue to have an impact. We also focus on providing practitioners with business resources and tools to survive in this climate of uncertainty. We provide practice management assistance and regulatory analyses for all of the myriad of rules and regulations that come out from the Centers for Medicare and Medicaid Services, among other agencies, and support our members. We created many years ago a health policy handbook, which we update every Congress. I did bring some with me. They're on the table. This is a great resource. I encourage you, if you're a patient here, to take one. It has sample letters, acronyms, glossaries, information about how to communicate with your congressmen and senators. We also have it available electronically on our website. Our 2015 advocacy agenda was, this year we were quite pleased with the success that we had. It was an unusual year in Congress where they actually got stuff done. Doesn't happen, I don't think it's happened since I've been at RPA, and I just celebrated my 20th anniversary there, so it's been an unusual year. By passing MACRA, which I'll talk about in a minute, equitable reimbursement for physician services in Medicare was passed, and coverage for non-ESRD patients to receive dialysis for acute kidney injury was passed. Federal funding for quality measure development was included in MACRA. And to some degree, MACRA addressed congressional oversight of Medicare quality initiatives. The extension of immunosuppressive drug coverage did not have any legs in 2015, and because of the Affordable Care Act, I think we're transitioning to this living donor issue as opposed to funding for immunosuppressive drug coverage. We activate our grassroots through Voter Voice, which is an easy way to electronically contact your congressmen and senators. You can do this through the RPA website. You don't have to be an RPA member. What we provide is a template of a letter. You can personalize it, and basically it automatically goes to your congressmen and senators based on your zip code. And it's really important that they hear from many, many people, because they do count these emails that they get. And so it's important that they hear from a lot of people on a given issue. Here's some pictures of our participation with AAKP in our recent Hill Day, and Tom Marino was speaking. As Todd mentioned, going up to the Hill together, patients and physicians, telling your story, letting these elected officials know how kidney disease affects you where you live and where you vote. There's nothing more powerful. So as I mentioned, MACRA was passed. The president signed the legislation on April 16th, and I had the good fortune of being on the Rose Garden for the celebration, so that was pretty fun. What is MACRA? Basically, it ends the annual fight physicians have had to have going to Congress and begging for not having a 21% cut in their payment and actually having stability in physician payment. So we now have a 0.5% payment increase through 2019. All of the incentive programs that you may have heard about as we move to quality-based payment, physician quality reporting system, meaningful use, the value-based modifier, all of those are combined into one program with this legislation called the Medicare Incentive Payment System. Everything has to have an acronym, that's MIPS. There will also be a 5% payment bonus for participation in alternate payment models like ACOs and ESCOs. $75 million was provided for quality measure development. Now, how that money gets allocated is still up for debate, and we're working through the American Medical Association to make sure that the specialty societies like the RPA and others in other disease areas get that money so that quality measures are developed appropriately and are evidence-based so that they make sense for the patient population that our physicians are caring for. It also extended the Children's Health Insurance Program. Another big win this year was receiving payment for dialysis for those patients who have acute kidney injury in outpatient dialysis facilities. It used to be that those patients had to go to hospitals to get dialysis, and the cost of that to the Medicare system was much greater, 3 times as much as what is paid to a dialysis facility for those very same services. And so that provision will not go into effect until January 1st, 2017. We're not sure why that was how it was included, but that's how it was included. And oddly enough, it was included in the trade bill as opposed to a Medicare bill, but we were okay with that because it still got passed. A broad kidney bill was introduced February 26th, and Todd referenced this. It's the Chronic Kidney Disease Improvement in Research and Treatment Act. I do have a fact sheet about that bill on the table as well. This is the kind of thing that we call leave-behinds. When we go to congressional offices, we leave behind these issue briefs, which is sort of the call to action. And what we want, you have to be very specific when you go to a congressional office about what do you want us to do with this information? Well, we want you to co-sponsor this bill, and then they can decide to do it or not. But you have to be very specific about your ask. The provisions in this bill include refinement of the dialysis facility payment, expanded kidney disease research, protecting patients in Medicare Advantage, and there are provisions relating to promoting transplantation and home dialysis. Right now, this bill has 8 co-sponsors in the Senate and 41 in the House. It is highly unlikely that this bill, as it is, will pass in total. The idea of having a bill like this with a menu of items is so that some of these items can be picked up and put into other legislation that is broader, similar to the AKI provision getting passed in the trade bill. So there are other vehicles that go through Congress, and congressmen will pick up, or their staff will pick up some of these provisions and put them into broader bills. The Medicare Telehealth Parity Act was introduced in the House July 7th, And this will also increase access to home dialysis therapy. I realize some of you are now on home therapies, and this is a great thing to promote home therapies. It will allow for the patient option to have less face-to-face visits for physicians on a monthly basis, which extends the ability for patients to dialyze at home and not have to come back to the physician's office if it's inconvenient or not necessary. And the rest of the services can be provided by telehealth. We're talking about allowing originating sites to be the home and the dialysis facility. Right now, that's not part of the telehealth provision. There is no Senate companion, which it would need, and currently it has 20 co-sponsors. But the interest in telehealth is growing. The interest in telehealth as it can provide greater access to health care is growing on the Hill, and so this is a real opportunity. In May, the Senate Finance Committee had asked for input on ways to improve chronic care delivery in Medicare, and clearly chronic kidney disease is a poster child for chronic care delivery. So we had submitted comments talking about the potential value of alternate payment models, chronic care management codes in the Medicare fee schedule, and how nephrologists can utilize these chronic care codes to take care of chronic kidney disease patients more comprehensively. We also talked about in our comments telehealth and the ability to remotely monitor home dialysis patients. We talked about the need for patient engagement and shared decision-making in your care. RPA does have a clinical practice guideline on shared decision-making in the initiation and withdrawal from dialysis. It is available for free by download through our website, and there are tools in there, as Dr. Johnson spoke about, just one of the treatment options being conservative management. That's addressed in our guideline, and it's a very good resource for you. We also addressed improved care coordination between primary care and nephrology practices, and actually in the proposed rule for physician payment for 2016, the Centers for Medicare and Medicaid Services, CMS, is looking for input on how to improve care coordination codes and payment for care coordination. And again, nephrologists will be able to provide really valuable input on that because we do work so closely with our primary care colleagues. And RPA had also created an advanced kidney disease patient toolkit, which looks at stage 4, stage 5 kidney disease, pre-dialysis or transplant. As Todd mentioned, and I won't go into this, the 21st Century Cures Bill, there still is no Senate companion bill, and as he mentioned, this focuses primarily on research and modernizing clinical trials, and it would be great if it were to come to fruition. Speaking a little bit about nephrology reimbursement, because doctors who get paid to care for kidney patients are benefiting from some of the new codes that have come to pass. Advanced care planning codes now have work values assigned to them, and so nephrologists can now get paid for counseling patients regarding advanced care planning. Also, home dialysis codes were added to the list of telehealth services, but the originating site issue was still not addressed in the proposed rule, even though our comments did address them. The final rule is expected November 1st, and that will guide physician payment for 2016. We did provide input to CMS on the conditions for coverage. They did sort of a soft request for what should be included in the next update. As you may know, the conditions for coverage govern dialysis facilities, and the first update took about 26 years to be done, which is unbelievable. The next update was about 8 years, and so our comments addressed the need for regular and more frequent updates. We talked about an update every 5 years on some regular schedule so that it's not, oh, we haven't updated the conditions for coverage for 20 years, maybe we should do that. Kind of crazy. The other thing that we talked about was facility survey and certification. Dialysis facilities must be surveyed and certified by Medicare in order to maintain their Medicare status, and there's a lot of inconsistency in how that occurs throughout the country, and so we talked about the need for more consistency to ensure consistent quality of care. We did have some successes this year through the efforts of the community coming together. we had one Medicare carrier who was basically saying that dialysis patients don't really need to, it's not medically necessary for dialysis patients to be seen twice, 3 times, 4 times in a month, which is kind of crazy. These patients are sick, right? So we convinced the carrier that this made no sense and that dialysis patients, by virtue of their disease, need to be seen 4 times a month, and if the physician sees the patients 4 times a month, should get paid to do that. And it was fixed, and they shifted their thinking, so that was a good thing. There was also a policy that was preventing patients from getting things like antibiotics because the CMS policy was requiring that physicians have pre-authorization for those drugs, and so a patient wouldn't be able to get their antibiotics, for example, without the carrier pre-authorizing that, and the community came together and explained how stupid this was to CMS, and they changed their mind. So that got revoked, and that was a good thing. Noridian is one of the Medicare carriers in the country, and they had a policy that was limiting frequency of dialysis to 14 sessions a month, which negatively impacted home therapies. Again, that policy was not implemented based on them seeing the light. And we also were able to get ESRD patients to be able to utilize the hospice benefit in the 2015 hospice rule. So by virtue of having end-stage renal disease, that does not prevent you from having access to hospice care. We also were able to obtain payment parity for hospitalized home patients so that if a home therapy patient is in the hospital for the month, there is still compensation to the physician for taking care of that patient for the whole month, even if they're in the hospital. Again, promoting home therapies and not providing disincentives to home therapies. There is also a new code that's going to be implemented January 1st, 2016, that will allow physicians to get paid for central blood pressure monitoring for kidney patients. We have several vehicles through which we impact policy and regulations. We have a nephrology coverage advocacy program through which we involve the carrier, the nephrologists who represent each area of the country on the Medicare administrative contractors. So the Medicare carriers have local coverage policies, which are different from the national CMS coverage policies. And so our nephrologists are able to impact those local policies, similar to what I mentioned about Noridian and how they were trying to put in disincentives to home therapies. As Todd mentioned, money talks. RPA is the only nephrology group with a political action committee. This is really how we get one-on-one breakfasts with congressmen and senators where we talk about the issues. A political action committee is basically a group of people who elect or re-elect candidates to public office and represent a common ideological interest. We have a separate fund that supports the PAC, and anyone can donate. We created our PAC in 2005. It's not red or blue. We support candidates, Democrats, Republicans, basically focusing on the issues that we care about in terms of health care. We're not looking at what their stances are on other issues. It's really what they care about related to health care. So what's in store for the future? Well, everyone's still finding their legs. We just heard this morning that Boehner has resigned, so that's going to be kind of interesting. Yeah, surprise, I had no idea. So don't know what's going to happen. So when we talk about the future, I don't have a crystal ball. I don't think any of us have a crystal ball. But 2015 has been a year for stuff to happen because it was not an election year. Basically, during an election year, all the focus is on the election. And it's very hard to have legislation passed. This year, stuff actually got done, and it was a great year for health care. There's still much more to do, though. And some of the concern we have is that now that physician payment has been fixed in Medicare, there is no longer going to be a Medicare vehicle every year through which new items can get placed. It's always been this bill that we know annually has to get passed, and so we've been able to look at other provisions that need to happen. So now health policy folks in Washington have to figure out what are the vehicles we can use to get health care priorities passed in legislation. One of the things that's really important moving forward is that the Secretary of Health and Human Services has made proclamations, and the way things are moving is that healthcare is going to be based on value. So patient outcomes, quality metrics, and so your role in that moving forward is going to be critical. There are patients who serve on the National Quality Forum, and that's an entity that reviews and endorses quality measures in Washington. I would encourage you in your involvement through AAKP to become aware of, what are the things that matter to how you feel about how you are taken care of, and you will have a critical role in how those quality measures are developed moving forward. Importantly, policy development is often out of alignment with innovation. For example, in terms of meaningful use, which is health information technology, Renee Elmers from North Carolina, who's a nurse, had introduced legislation, it was called the Flex-It Bill, to address meaningful use. Basically, there's all this policy now for how health information technology needs to be used in healthcare. And unfortunately, the vendors who support health information technology are not necessarily in sync with what the requirements are for payment of meaningful use and compliance with meaningful use. For example, the health information systems that a physician's office uses do not necessarily talk to the information system that a dialysis facility uses or that a hospital uses. And so the interoperability issues of these systems are extremely challenging. And so when we talk about medication reconciliation or transitions of care when you're in the hospital and you come back to the facility, all of those issues should easily be available in an electronic format, and it's not so easy. So that all has to be figured out at a much higher level. So right now, payment is somewhat stable. There's a challenge, there's always a brain drain at CMS that, the people you get used to working with and who learn your issues are not always going to stay where they are. They may stay at CMS, move to a different area, they may leave government, and so it's a challenge to keep them informed about what our key issues are. Everything's about the bottom dollar, so CMS must spend wisely in terms of the Medicare program. And for better or for worse, CMS and the Congress are no longer ignorant about kidney care and ESRD. So they're more familiar with what our issues are. However, there is a microscope on our issues. So positive, negative, And as Todd mentioned, RPA participates in numerous coalitions, and I would also echo his remarks that being part of a larger entity, regardless of what it is, elevates your issues. It also elevates them if you speak with one voice. So when we go to Congress as a kidney community and we are together on an issue, we have legs. We get traction. If we fight within our own community, we get nothing because Congress doesn't want to mediate that. But if we all go together and we are adamant about the need for more funding for kidney research or quality patient care metrics or whatever the issue may be, we will be much stronger and have much greater success together than if we are off doing our own thing. So again, I thank you. I look forward to the dialogue and discussion. One other thing I have, if you don't know who your congressman or senator is, I do have congressional directories, so you can pick one of those up.
First, I'd like to thank everybody, as Dale was speaking and talking about the materials that she had brought, the number of people who got up and went right over to get the books and everything like that. For AAKP, it shows that we have a patient audience here who's really engaged and wants to make a difference. A couple of things. In listening to the talent that's at the table today, you got the insight on currently what's going on in Washington, D.C. by people who are, again, real trusted experts, down to the level of detail that a congressman or senator expects of their staff. These folks deliver, and they deliver consistently. Having said that, with the level of detail that you've both gotten into, I wanted to throw a couple of questions at you with a patient audience, some of whom have come here for the first time. And one of them is, if you had to put your finger on an issue that you would say keeps your teams up at night, looking across the next year or the year to come for the kidney community, is there one issue that you think really says to your teams, wow, we need to make certain that the patient voice stays engaged on this one?
You go first. Just don't take my
So I'm going to take that from a macro level and a micro level. In the most immediate future, October 1st, the government could shut down, and that's a real possibility. So if the government shuts down October 1st, that has implications for everyone in this room, because that means that the people who work for NIH, the people who work for CMS, don't go to work. So therefore, policy comes to a halt, research comes to a halt, clinical care that's being delivered at NIH, innovative therapies that are being delivered at NIH come to a halt. Chris Van Hollen, who's a congressman in the district where RPA's offices are and where NIH is, was just at NIH meeting with the NIH director earlier this week, because it could be pretty devastating if the government comes to a halt. So that's on the macro level, and that's a real possibility. Hopefully that won't happen, but that's a real possibility. On the micro level, I would say the biggest area where you can have an impact in the next year or two are in the development of quality metrics for patients. I think that, by your participation with the physician groups in the development of quality outcomes, process metrics for everything from anemia management to high blood pressure control to bone and mineral metabolism, all of the areas that affect kidney patients. I think that the kidney patients have the most understanding, based on your experience, of how you feel and how it impacts you. So that would be my guidance.
Thanks, Jill.
So I'll start with Dale's micro, and then I'll do a different macro. So from a micro perspective, in August, the Kidney Health Initiative had a workshop around patient preferences with devices in the kidney space. And so I believe Carolyn Newland from FDA is speaking tomorrow. Just to recommend that session, but Sam Peterson helped organize this effort. And it was very important to have the patient perspective on devices, which is very different than the FDA's perspective, than the industry's perspective, and the nephrologist and other health professionals' perspective. So I think, just to echo what Dale's saying, that the more patient voice there is for measure development, but also from the innovation perspective, however you want to define that, is crucial. The macro issue, and the thing that keeps me up at night, is that nephrology has become the least appealing specialty for graduates of U.S. medical schools and increasingly graduates of international medical schools. And this trend started in 2002. So in 2002, that was the peak moment in terms of the most interest, based on the data, of student interest in nephrology. And it's just been dropping steadily since. My sense is that we probably reached bottom last year, possibly this year. There's a match between where residents match into fellowship positions. Those interviews are taking place now, and then people start putting their match lists in late October, early November, and the match takes place in December. So I'm waiting sort of on pins and needles to see what the numbers look like. It seems like the interviews are slightly better than last year. There seem to be slightly more candidates, but it's close. And so my hope is that this is the floor, and that it'll start becoming more appealing to students and residents moving forward. But that's a real crisis for the specialty, and has implications in terms of everything that Dale and I reviewed, and that Doug said as well. I mean, if we don't have the best and the brightest going into nephrology, and we don't have even an adequate supply of future nephrologists, that's going to have ramifications. So I think that, to me, is the sort of macro issue that I would pull out.
Thank you both on that. One other thing, taking a look back over your own professional careers in advocacy, in trying to get policy to move, just a question for you. What has the impact from your own perspectives and in the own short time that it's been out there, that social media has had, not just for patient advocacy groups, but in terms of how Congress and decision makers react to the power of voice coming on social media? What have you seen in your respective time?
Well, I mean, the first thing is members of Congress are narcissistic and they love having their photos taken. So pretty much every congressional visit has some photo component either with the staff or with the member or both. And what's nice about that is you can then send it out and instantly say, you know, thank you to Representative Marino for a terrific meeting, and then they start retweeting it, and you just get momentum. So I think that's a big change. I think more substantively, information's now exponential, and so there are multiple voices that are involved, and all of a sudden it just everything gets legs more quickly, and there's so much information that gets sort of thrown out bidirectionally. So from the member trying to promote things, so if you say something positive about them and they pick up on it, they start retweeting it, and it becomes a sort of self-feeding monster, if that makes sense. I think from my experience, so I worked on Capitol Hill in the late 80s, and at that time you would get these little cards, and as Dale said, we would collect them all and we would count them, and I'm not sure if it swayed decision making, but if the member knew, and it was a he, that he was voting against something where there were a lot of constituent cards, that he knew when he went back to the district and met with constituents, he was going to have a mess on his hands. But there was so much time. And if you move forward from that to now, where instantly on social media you can do the counts, it's a very different relationship. So I think it's exponential, but it's also a lot faster.
Okay.
And I would just add, the one advantage has been the ability for us to activate the grassroots, for people around the country to be able to provide feedback instantaneously to weigh in on issues. And so you don't have to write a letter. In fact, we encourage people not to write letters because they don't get opened, or they take forever to get to the congressional offices. So it's the ability to flood the offices and the people with information, and it's easy. It's so easy to do it. I mean, it takes literally a minute to send off a note to your congressman or senator. It's so easy.
By the way, one piece of advice, if you do send a letter, and I agree with Dale, you shouldn't, never, ever, ever write private and confidential on it, because what ends up happening is everyone in the office opens it and sort of says, oh, it's private and confidential, and it gets passed around. So don't do that.
On that one, Todd's not reflecting back on his career at all.
Yeah, no. Great joy.
We're going to do one last quick question because I have to mention this. Dale's going to depart here in just a couple of minutes because her last child is graduating from college. And so for a lot of reasons.
Yeah.
Well, thank you. Yeah, he's graduating in May, but this is his last parents' weekend this weekend. And so I figured, we're not going, he's a senior. And he's like, you're coming to parents' weekend, aren't you? I was like, sure, absolutely.
Yeah, we all know that means the boost for May is on. But one last quick question. A lot of folks sometimes were encouraging AAKP patients to take place in your Hill days, whether it's ASN, RPA, KHI. Sometimes we get this look of, you want me to go into this congressional office and do what? So just for the folks that are here, what do you think the largest fear is in meeting with a congressman or a senator that's unfounded? Like, a lot of people have a perception, but what is actually the truth from your perspective?
So they're just regular people, honestly. They use the same men's room or ladies' room you do. They usually right. They have the same coffee for breakfast or whatever. How many of you have been to DC to a congressional visit? Okay, so I want everybody to look around and see the people whose hands are up. So what I would encourage you to do is at lunch to find one of these people and ask them about their experiences on Capitol Hill. I've had the privilege of attending congressional visits with a few of the folks in this room, and I will tell you that there is nothing more powerful than when we walk into a congressional office and you, as a patient or family member, tell your story. You're the only one that knows your story, and you know your story better than anybody else does. You're an expert in your story and how kidney disease has impacted your life. And so you can answer any questions about that you choose to answer, and you know what could be done differently and better, and how that elected official can help you. And so I understand the fear and the apprehension of being on Capitol Hill, But I will tell you that once you walk in that first door and you have that first meeting, all of that fear just disappears. So I would really encourage you to talk to some of the folks that raised their hands, because there's no reason for that fear. These are just regular people.
I can't say it better, so I'll make a joke. I'll make two jokes. One is, true story, on my first day, so I started out as an intern and then got a full-time job, and sort of an interesting story. And the member of Congress I worked for had the unfortunate name of Thomas C. Sawyer. It's true. And he got his nameplate stolen about once a month. The first day, the chief of staff said, you have two rules. One, keep the member alive. Two, keep the member in office. And everything, and it's cynical, I know, but you'd be surprised. There were things that came up, and we would joke and we'd say, well, we don't want so-and-so driving the member to the airport because that person's not a very good driver. But if you think of that and what you can do to keep them elected, and you're a constituent, they want to interact with you. And you don't necessarily have to come to Washington to do it. They have offices in their districts. They're much more relaxed in the district. If you can get to know them and they can trust you and realize that you're going to tell, you tell your story, you tell them the facts, they can rely on you. You can say, look, I don't know the answer to that, but I'll get back to you. But I want you to understand what my life is and how I can be helpful to you to keep you elected. That will be valuable to them. The other sort of comical story I will tell is that one time after I left the Hill, I was a lobbyist for a while, and we were lobbying, and my boss kept referring, I'll just use Bradley, Senator Bradley, Senator Bradley, Senator Bradley. It'd really be helpful if you supported this bill. You've been a real proponent, blah, blah, blah. And at the end of the meeting, the senator said, I'm not Senator Bradley. So at the very least, make sure that you know the person's name. And it sounds silly, but if you do 5 or 6 visits in a day and you are a little careless, like my boss was, notice I'm blaming him, you can feel kind of foolish. So knowing someone's name is really important.
Okay.
Great. And Paul, we actually do have a couple extra minutes. So if we have any questions or comments from the audience, we have we have a little bit of time to do that.
Good morning. My question is, given all the information that we've done with Congress, and I know that we had somebody do dialysis in front of Congress, but a lot of times people that aren't in the situation don't realize the time consumption and the side effects of dialysis and treatments, as well as the time consumption of family members taking patients to dialysis, as well as doctors, as well as side effects. So when was the last time we've done some type of incumbency hearing with Congress with patients on dialysis in different modalities, PD, home hemo, in a in-center system, and family members that are being impacted by their work schedule to fit this in, which is very disparity, and it's very hard and stressful on the family as the unit as a whole, not to mention the financial issues. That's a whole nother question.
Go ahead, Dale.
So there hasn't been a hearing such as the one you mentioned in a very long time. There have been hearings on specific issues like home therapies and telehealth. But one of the ways to communicate the messages that you referred to in terms of the toll that dialysis takes on a patient is to invite congressmen and senators and their staffs to dialysis facilities. And we've coordinated some of those visits during recesses when they're not in Washington, which is sometimes more than they are in Washington. So when they're in the home districts, in August, winter recess, et cetera, the staff are especially very interested in learning about, what happens in a dialysis facility, what's involved in the care. I will tell you, I started working, I had no experience in kidney disease at all when I started in the work world and when I graduated from college. And my first job was actually working at the National Kidney Foundation in Washington, D.C. And my very first day on the job, the doctor who was in charge of the medical advisory board invited me to his unit at Arlington Hospital, and I got a tour of a dialysis facility. I knew what I was going to be, what I was dealing with. I had no idea. And I encourage my staff to also go to a dialysis facility when they start with RPA, because they need to understand what it is we're talking about. So that's probably the best way. Hearings are an option, but I think that the individual relationships that you build locally and bringing them to a dialysis facility, and I'm sure that the AAKP staff can be a good resource for you in helping with that and coordinating with the physicians and the medical directors that are at the facility, because we oftentimes have to get permission. But that's a real tangible way for people to understand what's involved.
Okay. Terry, do you have another one?
One more.
Okay, great.
My name's Nancy Spaeth. I'm from Seattle. And I have two things. I want to get the sodium out of food in the grocery store. I hate it when I see a can of soup and a serving is 1,300 milligrams, because I keep my sodium under 1,000 milligrams a day. And my other thing is I want to educate and find a better way to educate family practice and general practitioners to refer their patients with kidney disease sooner, so that we can catch them when they're at the second or third stage and prevent dialysis for them.
So let me take the second one first. We have tried to engage both the American Academy of Family Physicians, the American College of Physicians, and you may have noticed on Dale's slide, RPA works closely with the American College of Physicians also. And I was disheartened, it'll be 2 years ago in the fall, when they put forward clinical practice guidelines around screening for kidney disease. And I recognize it's a complex issue. I recognize they have a guidelines process that doesn't include sort of experts from the field. It's based on the literature review, so sort of pause and think about that for a second. Our press release, I was quoted as calling the guidelines irresponsible, which probably wasn't the smartest career move I've ever made. Although some people liked it, but I think most people thought I was irresponsible for saying that. But I share that frustration, and I'm not sure. My sense is, and I'll answer your second question, but then I want to make sure that I know Dale has insights into this as well. I've been struck, it seems like the general internists and the family physicians are so under siege at this moment in time, more so, I would argue, than probably the nephrologists. And so it's hard for them to even step back and think about this issue the way they probably should. I know that's not an answer, and I think the only way they're going to pay more attention to it is if they hear more and more and more from the patients, as well as if we can do a better job of constantly, in these different forums, constantly keep raising the issue. I know that's not a satisfactory answer, but that's just sort of the reality of this moment in time. I mean, is that a...
So I would agree with that. The only thing I would add is, as these alternate payment models come into the fore, and we're talking about the patient-centered medical home, and we're talking about accountable care organizations, there are now going to be payment incentives for primary care physicians to work with their specialty colleagues, including nephrologists, to better coordinate care for each patient population. So I think you're going to see it change, and I think the payment system is reflecting the need for that change to move quickly.
In terms of your sodium issue, I've been struck, if I had to say the four parts of the FDA as we've been working with them, the devices has been the most engaged and has really welcomed the input from the community, particularly the patients. Drugs is starting to come on board, and I think we'll be close to patients soon, to devices soon. I think biologics is probably going to be the next to come online. That's a little trickier, and there's a lot happening in terms of biosimilars and things, but that seems to be the next one. Food is a mystery to all of us, that part of the FDA. Even people in the FDA, I think, are confused by food, just to be incredibly blunt. However, they've recently announced that they've named a new commissioner, Rob Califf, who's a cardiologist from Duke, who basically created in cardiology what we were trying to model in kidney disease. So he's been incredibly supportive of what we're trying to do. If he's confirmed, and I think he will be, but there will be some drama in terms of his confirmation. And there was an article that described him as sort of Nixon in China with the FDA. I would describe him as sort of Nixon in a China shop. He will force change, and I say that as a compliment. I think he's the best thing that could happen to the FDA. I think there will be an opportunity to really sit down and talk about better labeling for people who have kidney disease. So I think that opportunity is going to come, maybe not this year, maybe not next year, but I think at some point during the KLF administration. I'm looking at Sam. Do you think that's fair? I mean, yeah. So I think there's an opportunity there if we can really tell the story and articulate it well.
What I'd like to do is thank both of our guests and stay on schedule here, but most importantly, don't miss the fact that this is historic. This is the first time the two of them have been together. They came here to AAKP.
We hang out together all the time.
Yeah, apart from the nightclubs and the parties, no.
By the way, Bradley and Gore are no longer in the book, if you're looking for them. Sorry, that was my last one.
But again, if you could, please give them a very energetic round of applause and thank you.
Thanks.
So a couple of minor announcements here. First, the exhibit hall in the Wellness Center is now open, and take your time, please.